This is the third of the classes on the character, dysfunction, and potential of American healthcare, and I've held off talking about about healthcare reform pretty much until this session. So that's what we'll focus on tonight. Before I do that, I'm going to take you on a tour around the world, show you how some other countries treat their healthcare system, what works, what doesn't work about that. And then we're going to get into to healthcare reform. But in terms of kind of where we've been, the first class we looked at the sort of the character of the system and why it is the way it is, and we discovered many things. For good and bad, the U.S. healthcare system reflects American values, history, and experience. At the same time, all of the energy, all the money, all the creativity really drives global innovation in clinical care, pharmacology, diagnostic, medical devices. The vast majority of innovation in healthcare occurs in the United States or is funded through the United States. You know, when you look at the demographics, if we don't do anything, it's at 17% of GDP right now. The explosion in chronic disease, the costs will just keep on rising on a per capita basis. One of the big problems is how much overtreatment or unnecessary care takes place. Some estimate that it's as much as 30 to 50% of all care. So if we're able to figure out how to provide the right care in the right amounts at the right time, we can begin to address some of the structural challenges. And that the long-term trend for healthcare activity has been to take money out of hospitals and put it into alternative settings, and that will likely continue. So that was sort of class number one. We talked about how demand doesn't drive supply, that it's the other way around. Supply drives demand. That's part of the reason you get the overtreatment, the reimbursement systems, the payment systems that are frequently counterproductive. At the same time, the great technology and so on. Last class, we spent a lot of time talking about something you wouldn't expect, closed systems, why traditional economics doesn't work, why traditional approaches to risk management don't work, how we're experiencing in ever greater frequency what we call black swan events, large, high impact, very rare events that everybody can explain in retrospect, but nobody sees coming at the time. Anybody think of a big black swan event that's happened in the last week? Goldman Sachs. That one I saw coming. Iceland, right. The volcano, no big deal. Volcano erupts, happens all the time. This one happens to get into the airstream and shut down Europe, and people get stranded. We're going to have more and more of these kind of big, rare, large impact events as the world becomes more complex and interrelated. So when we are in a complex world, closed systems don't help out very much. Open systems that look at evolutionary mechanics, sort of bottom-up behavior, that solutions emerge rather than are dictated from on top. And there really isn't anything more complex than healthcare. So part of what we're going to talk about today and why I put this in the class last week was having an understanding of complexity and different ways to think about management in a complex environment will have a lot to do, I think, with how well we're able to integrate care and make real progress in bringing down the cost of healthcare while improving quality and overall healthcare statistics for the population. And as part of that, management systems that emphasize teamwork, diversity of perspective, power of stories, the importance of experimentation are all very effective strategies and tools in whatever industry you're in or you go into, but certainly in healthcare. And the one you can't read here on the bottom, which is that we looked a little bit at what's happening outside the U.S. shores, and we see that in places like India, Singapore, even the Caribbean, very modern healthcare facilities are being built for a fraction of the costs in the U.S. And if we don't address some of the cost and quality issues in our country, it's very likely that some business will go offshore. So while some people look at the U.S. healthcare system as a closed system, it's in a market just like everything else, and if we're not competitive, we run the risk of losing some of the surgical volume to other countries. So the character, why it's the way it is, something about closed systems, complexity, all of that brings us right up to today, which is healthcare. And so here we're going to talk about, we're going to go around the world talk about the different models that other countries have employed, what works, what's a challenge. Nobody's got it completely perfect, but other countries do spend less and have better overall healthcare statistics. Healthcare has now happened. What do we do? And even if healthcare hadn't happened, there is just enormous need to move toward a care transformation process that yields better outcomes at a lower cost more consistently. So we're going to talk about the logic, pressure, and mechanics for that. And once we have that as a basis, we can start to talk about the art of the possible. How can health systems, how can doctors, how can hospitals, how can pharma companies, how can that all come together in better ways? And then we'll conclude with a couple of observations about how to get it right. So for inspiration, great American philosopher Yogi Berra, that predictions are difficult, especially about the future. He also said the future ain't like it used to be. Truer words never spoken. But this very powerful passage from the book of Proverbs, the Old Testament, where there is no vision, the people perish. So part of what I hope to do here is give at least some of the vision about healthcare and how we can begin to think about improving a system that has confounded change in so many ways. Then a couple of quotes from Peter Drucker, the management guru. One, the academic medical center is the single most complex organization designed by human beings. It's quite a statement. And secondly, this is just a great quote. The customer rarely buys what the company believes it is selling him or her. Figuring out the job. Why are you being hired? How do we solve the problem? Some pretty basic managerial lessons, but it's remarkable how often, as Drucker observes here, the company believes it's selling one thing and the person or a company on the other side buying it is buying it for another reason. So figuring out not only who the customer is, but why they're employing you to do what it is you're doing is remarkably important. And I'm going to talk a little bit about that. So around the world, Great Britain, Japan, Germany, Taiwan, Switzerland, and finally the United States. This is a slide we had in the first class. It just talks about how complex and varied and involved healthcare is. But it fundamentally comes down to these three questions. And it's a very good way to think about national health systems around the world. Who receives the care? How much care do they receive? And who pays for it? Those are the three questions. So there are four basic models. And I did cover this in the first class as well, so I'll do this very quickly, particularly since we're going to talk in some detail about specific countries. The Beveridge model is named after the creator of the British healthcare system. It's basically what's called socialized medicine, healthcare provided and financed by the government through taxes. Nobody sees a bill. Hospitals and clinics are government owned. Most doctors work for the NHS, the National Health Service, but there are some private doctors as well. In Germany, the oldest public health model put in place by Otto von Bismarck, Kaiser, in the 1880s as part of a way to unify the city-states of Germany. And he decided that creating a welfare state was a very positive way to unite the German people. They created what they call sickness funds. They're really insurance funds that pay for health care for the entire population. The doctors in the hospitals tend to be private. The levels of coverage and regulation vary. Many countries employ that model, but most notably Germany and France. The national health insurance model, sometimes called the single payer model, it's what Canada uses, where the hospitals and doctors are private, but the government takes all the risk and provides for all health care. And then finally, the out-of-pocket model, which is in most of the world, which is if you've got money for health care, you pay for it. If not, you're out of luck. So 200 countries in the world, about 40 have national health systems. In the other 160, it's by and large the rich get medical care and the poor stay sick or die. And the interesting thing about the United States is we have a version of all of these. The Beveridge model, socialized medicine, is what the Veterans Administration does. The Bismarck model is what most people have who have commercial insurance, whether through Blue Cross or United or Anthem. The national health insurance model is just like Medicare. And then, of course, even until this day, we have roughly 50 million people without health insurance who either pay out of pocket or are picked up by the charity components of the system. So generally the program goals: keep people healthy, treat the sick, and protect patients and their families from financial ruin caused by medical bills. So these are the four models. We're going to focus on countries that exemplify the first three. So the United Kingdom, 61 million people. They spend 8.3% of their GDP on health care. No family premium. Can you imagine that? You just get health care, no monthly premium, no paper to fill out. Almost no co-payments or no co-payments for most services. 5% for prescriptions, and the prescriptions already carry low prices, and young people and older people don't have to pay that. Socialized medicine, as I talked about. Very strong focus on preventative care. General practitioners receive extra payments for keeping patients healthy. Very low administrative costs. On the negative side, what they call the queue in Great Britain, if you have an elective surgery, you sometimes have to wait as long as a year to get that surgery. They ration care through that. It becomes an issue at election time. There is limited choice frequently. They are putting through reform to give patients more choice, and there is a growing private health care sector, and they're struggling with costs too. It's going up at a rate greater than inflation. But that is Great Britain. Japan. How many people knew that Japan was twice the size of Britain in population? 130 million people. 8% of GDP spent on health care. Average family premium is about $280 a month, and employers pay half of that. Co-payments are 30% of the procedure cost, but again, they're very low cost, and there is a monthly cap over what you can pay. So it's a social insurance system. There's mandated coverage either from your employer or from a community nonprofit. Public assistance for those who can't afford the monthly premium. Most insurance is private. The insurers compete based on service. Doctors and hospitals are private. The country is among the world's best in health statistics when you look at longevity, diet, lifestyle. You can go see a specialist. There are no gatekeepers. But what you do have is very strict price control engineered by the Ministry of Health. And they essentially produce a book that's the size of this, telephone book that has every single procedure, every single cost for an overnight stay, everything you can imagine. And it's the same throughout the country, and physicians have to look it up and charge that way. So it's updated every 2 years, and it keeps costs down. A concern is that they may spend too little on health care. Doctors, relatively speaking, are working very hard for incomes that are substantially less than they would be in other countries, and even substantially less than equivalent professionals earn in Japan. 50% of the hospitals are not profitable, not nonprofit. They're losing money. So again, this strict cost control may be too strict. So physicians underpaid, no limits on patients seeing specialists. So if someone has a proclivity to go see doctors and participate in the health system, that can harm. And some patients have no medical home. So by medical home, someone who oversees their general care. So that's Japan. Germany, 82 million people. Relative to both England or Great Britain and Japan, spends more, 10.7% of GDP on healthcare. So now it's over 11%. Again, the average family premium is significantly higher than Japan's, $750 a month. It's pegged to income, so the more income, the higher the premium. And then co-payments, $15 every 3 months, and some patients are exempt from that. So this is the social insurance system. They have the sickness funds, mandated coverage. If you're poor, you get public assistance to get into the system. The sickness funds cannot deny treatment. They compete for members. They're paid by enrollment, and they get bonuses the more that they enroll people. So even though the sickness funds, by and large, for basic care are nonprofit organizations, there's still an incentive to sign up members and get high ratings from those members for the care they provide. Private doctors and hospitals, single payment system. Patients can go to see a specialist directly. There's some concerns. Doctors feel they're underpaid. This is interesting. The wealthiest 10% in society can opt out and have private insurance. There's some concern that this will create a two-tiered system. Obviously, that gets them to see doctors more quickly, and so on. So that's Germany. The way the cost control works, since everybody's private, is every 2 years a coalition of providers, hospitals and doctors, comes together with a coalition of these sickness funds, and they hammer out one schedule for everybody. And so again, there is, even though everybody's private, there is this sort of global universal coverage to how much Germany will spend on healthcare. Taiwan, pretty interesting. Small country, relatively recently prosperous. They only spend 6.3% a year on healthcare. Their average family income is $650 for a family of 4. Co-payments are what you see. What's interesting is Taiwan in the late 90s decided they were wealthy enough to have universal health care coverage. So they set up a study. They hired a professor from Harvard School of Public Health to oversee it. And they went around and studied 12 or so health systems around the world. Actually really liked the Medicare system, believe it or not, and patterned much of what they have on that. So it's a single-payer system, like Canada. All citizens have to have insurance. The workers share the system's cost. Others pay flat rates with the government's help, and the poor and veterans are fully subsidized. What's remarkable is, they had 12 countries they looked at, not 18. But they were able to expand their coverage by 40%. So they took it from 60% of the people having health care coverage to 100%. And they did it while decreasing the rate of health care spending. Remarkable accomplishment when you consider that health care spending in the U.S. has been increasing at rates greater than inflation, for just about forever, since the 60s anyway. Also a very technologically savvy country. So in addition to having a single-payer system, everybody gets a smart card, and on that smart card is all your health care information. When you go to the doctor, you plug it in. That automatically pays for the procedure, results in some of the lowest administrative costs in the world, 2% versus 20+% in the U.S. And on top of that, if you're overusing or you're going to specialists very frequently, even though there are no limits to do that, a buzzer will go off at the Ministry of Health, and they will call the person to inquire as to why they're using so much health care and intervene if they have to. So a remarkable use of technology. And again, their concerns, they may be spending too little on health care. It's a political process to increase the spending, always hard to do. The government borrows to cover its unfunded cost. No gatekeeper for specialists, but as I said, they do administer that technologically, and that does address some of the issue. And as the electronic monitoring identifies overusers. So very interesting that that country in the late 90s was able to put in place a full system and do it for a fraction of the per capita costs in the U.S. and be very sophisticated about technology. Switzerland, very small company, and I've included it here for a couple of reasons. One, they also relatively recently in the 90s, went to a national system. They had a vote. It barely won, 50.2% to 49.8%. It mandated coverage. Those without coverage were assigned an insurance company, public assistance to cover premiums for low-income people. But what was interesting about Switzerland, very strong pharmaceutical industry. Companies like Bayer and Novartis, who were opposed to healthcare reform, but they were able to overcome it, that opposition. They also had a very strong private insurance lobby, and they were able to overcome that. Now, their costs are relatively high at 11.6%, and you can see the rest. So relative to other countries, high. But here's an example of a highly industrialized country with a very independent population that was able to establish a national health system. And today it's, fast forward 15 years, it is remarkably popular. It's one of the things you can't touch. Interesting to see as the U.S. system goes through reform and becomes entrenched. Will it move from a position now where most people are against the reform to one where over time they learn to embrace it? So insurers negotiate with providers to set the prices. The government establishes drug prices. And interestingly, with these Swiss pharmaceutical companies, they pay more for drugs than other countries in Europe, but significantly less than here in the United States. Insurers can't make profits on basic care, but they can on supplementary care. And it works despite the strong, as I said, strong pharmaceutical and insurance industries. So concerns, very high cost, higher drug cost than other countries, no gatekeepers, although some insurers do offer discounts for gatekeepers. So again, really interesting example. Then you come to us, 334 million people. This was 2006 data, so we're up to 17% of GDP. Payment sources, 55% private, 45% government. Multiple structures, we've been through that. 60% of hospitals are nonprofit, about 20% are governmental, and another 20% are for-profit. Patient access to specialists and services varying according to coverage plan. Huge variation, all kinds of access issues. Insurance companies can deny care. Most insurance companies are for-profit. Makes us unusual relative to the rest of the world where, at least for basic care, it's either provided by the government as it is in Great Britain or by nonprofit insurers as it is in Germany and Switzerland. Insurers can make substantial profits on supplemental care, but for basic care, it's nonprofit. Hospitals and doctors provide significant levels of free care to the indigent, but again, that is done in a somewhat haphazard manner. Urban inner-city areas will be crowded with higher levels of indigent patients. So concerns, remarkably high-cost system, many Americans without insurance coverage, very high administrative burden, partly because the insurance companies spend enormous effort trying to decide who should be in and what treatments people should receive. Underfunding for promotive, preventative, and chronic care. You might remember in the first class I said it's remarkable that there's money in the system, as much money as you need to amputate feet or arms if someone has diabetes, but virtually no money in the system for people to manage their diabetes and keep the amputation from occurring. Different payment rates for the same procedures, distorts practice patterns and facility distribution. So again, it's not unusual for hospitals and doctors to receive payment as high as 130 to 150% more than their costs from certain commercial insurance companies. And it doesn't take a genius to know that if Medicare is only paying 80% of your cost and somebody else is paying 150%, you're probably going to try and figure out how to get more of those people that pay the higher rate. So we have a system that's built on differential pricing rather than the uniform pricing. Yet we spend a lot, and overall our health statistics are not as competitive. So relative to the four countries here, Japan, Great Britain, Germany, and Switzerland, we have the lowest life expectancy, highest level of infant mortality, also the highest level of obesity. Interesting on MRI units, United States is substantially greater than Switzerland, Germany, and Great Britain, but the Japanese are heavy users of technology and imaging equipment. But what the Ministry of Health does in Japan is when they see usage going up, they artificially push down the rate per use, the unit cost. So what's happened is that Japan has become very effective at doing these types of imaging services for lower per unit cost. It's actually developed a fairly robust export industry in taking low-cost imaging machines and sending them to countries like, for example, Africa, certain parts of Asia that are looking for less expensive ways of accomplishing the same thing. Pretty interesting. So 40 national health systems around the world, by and large trying to keep people healthy, treat people when they're sick or injured, and protect families from financial ruin caused by medical bills. Because they have these goals, it's not unusual that, or not maybe not a surprise that they have universal coverage, individual mandate. So if you're in this, yes, go ahead.
On the examples that you just showed us, is there any country, Taiwan or Switzerland, that had the same problems that U.S. had and have been able to change their system to some better numbers? For example, percentage of GDP is now better than what it used to be. So have any of those countries showed progress?
Well, I mean, you saw Taiwan that they were, before they went to universal coverage, only 60% of their people had health care insurance. Now 100% do. Well, it went up a little bit, but it's only 6% or 6.5% compared to, close to 17% for the U.S. And they've actually been keeping a lid on their health care expenditures because the government determines how much they're going to pay. Actually, the government and the legislature, they have to vote on it in that country. But there are cost pressures there, too. Unfortunately, the organizations bearing the pressure are the providers, the hospitals, and the doctors. And at some point, that leads to rationing of care and suboptimal use and so on. And so getting the formula exactly right of how much we should spend, how much we should pay providers, and so on, absent market mechanisms, is difficult. It's a regulatory process. Yeah.
We had a session at the Booth School a while back on the U.S. healthcare industry. Yeah. I myself am from the Netherlands. Okay. One thing that surprised me...
They pay for euthanasia, though.
They believe in euthanasia, but I pay $50 a month for 100% coverage here in the U.S. So that's the difference, huh?
Yeah.
And so they don't pay for euthanasia. Yeah. So what that keynote speaker there argued is that an important factor of how these systems differ is how fragmented the healthcare industry is. In Europe, there's these governments, the British government, the French government, they collectively bargain with the industry, with General Electric, and on equipment, as well as with the drug providers, and also even price cap the drugs. Yeah, and that pushes basically down the prices. So that speaker argued that that is something that's missing here in the U.S. That the HMOs are very fragmented, there's no collective bargaining going on, therefore there's a lot of supplier power with the industry, that drives the prices up, that drives the premiums up.
Well, and the payment mechanism is largely a reimbursement system, so doctors, hospitals paid for activity, not necessarily for outcome. So we have this very odd circumstance where supply drives demand rather than the other way around. So if you're in a community that has more heart hospitals and more cardiac surgeons, by and large that community is going to have more cardiac procedures than another community, and it's not necessarily correlated to medical need. So points you're making are true. So absent a market mechanism, the only thing strong enough to control prices is a strong regulatory mechanism. The debate tends to, on that point, tends to center on all of the, and I'm going to get into this a little bit later, so I don't want to spend too much time on it now, but tends to center on what always happens in a regulatory scheme, which is you need an army of technocrats to sort of figure it all out, and it gets complicated pretty easily, and before long you're making some mistakes. And it's part of, we have regulatory components in this country in Medicare and and Medicaid and Veterans Administration, and depending on how Medicare is choosing to pay for a particular service, it either creates an incentive to do it or one to prevent it, and it's just very complicated. In the rest of our world, we've become very good at, and you're at the business school, at letting markets determine value and prices, and that's been very hard to do in the United States. We're going to have a pretty interesting conversation toward the end of this class on sort of regulatory versus market-based reform, and is there a way to use markets more effectively to sort of address that problem? Great. So anyway, just on this, so most countries have, as you were saying, uniform pricing. The U.S. system is predicated upon differential pricing, individual mandates, so everybody's in the system. Here, the only place we have individual mandates is Massachusetts, and that only started a couple of years ago. And then, obviously, universal coverage if somebody can't pay, the state provides subsidy. And here we have 50 million people without insurance. So the U.S. is a significant outlier in terms of structure and cost. And so one way to think about U.S. healthcare reform that just passed is if you've studied math, and I know all of you have studied math, is that when there are outliers regress to the mean. So one way of looking at the U.S. system after healthcare reform is that there will be increased individual mandate, there will be higher subsidies and more coverage, there will be less pricing variation, so you won't see that Medicare being 80% of cost and commercial insurance being 150. They will come closer together over time. So one way of looking at it is we're regressing to the mean relative to what other countries have done. I think there's also a lot in the bill trying to change the provider mindset away from an activity-based approach to medicine toward one that looks at bigger bundles of payment, looks to integrate the care. So we treat the entire treatment cycle, not just these episodic incidents. So you want to treat somebody from the day they enter the hospital through discharge, through recovery, and there are penalties built in for readmissions that shouldn't happen. There are incentives for bundling payments together and getting it right the first time. There are these things called accountable care organizations that are modeled after the Mayo Clinic to try to have an integrated approach to care. And a lot of pilot programs. Many have criticized the bill for lack of cost control, and that may indeed turn out to be true. But what's interesting about the pilot programs is they've got many of them, things like looking at bundled payments and sharing improvement between hospitals and doctors and different ways of using technology, accountable care organizations, many, many different pilot programs. And if you believe, as I do, that in a complex environment it's impossible to know what's going to work, isn't it a smart idea to test many different systems and see which ones work, really, and then base the decision on which way to invest, ultimately invest based on real market experience. So that's in the plan as well. So we have healthcare reform. It's unleashed this veritable tornado of forces into the system. They're going to collide. They're going to interact with one another, sometimes in surprising ways. And it's almost impossible to predict exactly what will emerge from this. And I put a whole series of questions on here. Will we get more care coordination? Will we get lower pricing disparity? Will we move toward looking at outcomes rather than activity? Will it challenge tax exemption for healthcare systems? The current deal for society's deal is we allow hospitals like the University of Chicago Medical Center to be tax exempt, so no property taxes, no income taxes, no sales taxes. They're able to borrow bonds on a tax-exempt basis. They're able to invest their investment earnings, which are substantial at taxable rates, pay no capital gains. And the reason they get all of that benefit historically is that hospitals have provided a level of free care to those that couldn't pay for it. If suddenly everybody's in the system and paying, should hospitals be tax-exempt anymore, particularly given the pressure on municipalities for funding for everything from schools to roads to, Medicaid. Huge amount of, I think that will be one of the things that emerges. Will we see new business models? Will we see increased access in underserved areas? I mean, who knows? I mean, this is all going to kind of go out and into the market in a very organic, behavioral, bottom-up kind of way. Part of the reason I spent time on that last week was to give you some sense of how unpredictable it can be. These forces can be. So we've unleashed a complex and potentially disruptive force on the healthcare system, and people everywhere are scrambling around trying to figure out how are they going to respond. And some will get it right, and some will get it wrong, and some will consolidate, and some will be consolidated. Some strategies will work, some won't, and it'll be interesting to come back in a couple of years and sort of see how this all emerges. So this is where I begin to talk a little bit about this issue between regulatory reform and market-based reform. Anybody recognize this fine-looking University of Chicago gentleman? Hayek? Friedrich Hayek won the Nobel Prize, taught here at the University of Chicago, was a defender of liberal democracy and free market capitalism, and probably the most prominent member of the Austrian School of Economic Theory, which I'm sure some of you have studied. Anyway, I'm a little bit addicted to these great courses programs. I don't know if anybody's heard of them, but when I'm driving in the car, I will put them in and listen. They're basically university lectures like this one on different topics. And I was driving through Indiana a couple of years ago, and I was listening to a lecture on the Austrian School, and was talking about the great debate after World War II about whether to rebuild Europe on a market socialist model or a free market capital model. And, today you'd say obviously capitalism won, but at that point in time, if you think about it, we'd just come through the Great Depression. Europe was in ruins. We'd seen the worst excesses of the capitalist system. And, if you go back here in the United States, prior to the Great Depression, we spent about 2 or 3% of government, or total spending of the economy was government spending. Today it's about 20%. And that increase has gone to create the social safety net, so things like Social Security, unemployment insurance, and so on. So it was a pretty robust debate, and in some respects, even though capitalism appears to have won out, we do have elements of the market socialism. But anyway, Hyatt used the example of the price of tin to talk about the different way the systems would work. And we're all very familiar with the free market capitalism, and let's say the price of tin increases, and for him, prices almost had the power of language, so much so that all you really needed to know was the price of something that contained so much information people could make decisions based on it. So price of tin goes up, marginal users find substitutes, people that absolutely need tin adjust their processes and their prices, and at some point the market stabilizes and we get to equilibrium. Very kind of traditional market-based thought. If you said in market socialism the price of tin goes up, well, you got to have an army of technocrats first to figure out, well, why did the price of tin go up? And then you have to look at all the uses of tin, and then you have to prioritize those uses of tins, and then you have to assign prices for those uses of tin, and then you have to, make sure that nobody's cheating the system. And before long, it gets very complicated, and it's very easy to make a mistake. So I'm driving across Indiana, really enjoying this lecture, and I had one of those epiphany moments. I said, wow, that's Medicare. Medicare's got an army of technicians. They come together. They build these very complex pricing models for healthcare services. They adjust them for complexity. They adjust them for local wage rates. They adjust them for acuity. Anyway, before long, it gets very complicated, and it's easy to make mistakes. There's a lot of Medicare fraud. You need a big enforcement penalty, and so. As I thought about this, I said, well, this is pretty interesting. Sort of the free market capitalism, as people talk about reform, they say, well, let's let the consumers decide, consumerism on one side, and then a market socialist price would be Medicare for all, or single payer, or public option. If we went to the public option, and that ultimately became so. Pretty interesting pressures, and depending where you come out on the ideological spectrum, that will have a large influence on, so which way you come down on that. I tend to be more in favor of market-based solutions, but also want solutions that work. And we have something that's a little bit of a hybrid. There is some market-based competition, but there's a huge regulatory element. And the result has been 17% of GDP with some of the worst health outcomes of any advanced economy. So the end of last class, I gave you this couple of thought exercises, and just kind of look at these. So 1980, we had almost a little over 1,700 days in the hospital per 1,000 people. That dropped by 2/3. What do you think it'll be in another 5 years or 3 years? Think it'll be higher? Lower, right, so continue the drop. You know, surgery, 85% was inpatient surgery in 1980. By 2003, 37%, so it had been cut by more than half. Again, where will there be more surgeries done with inpatient stays or outpatient stays? Going down. And healthcare spending as a percentage of overall, somewhere between 40 and 45% in 1980, somewhere around a third or a little less than a third today. And will that continue to go down? So you look around and see all this investment in hospitals. Chicago, the metropolitan Chicago area is spending about $6 billion on new hospitals, including $700 or $800 million for the new hospital over here at the University of Chicago hospitals, without any substantial population growth, and in recognition of a long-term trend where activity has been going out of the hospitals and into alternatives. So, you know, as you think about business models, as you think about the future, building an incremental 1980s model to solve healthcare problems of the future may not work. And then I asked everybody to sort of think about what makes sense, what doesn't make sense, and I hope some of you did think about that. If we were on a board retreat, I'd actually pull out a whiteboard and I'd set you up in teams and we'd divide it up and then we'd talk about it, and we'd have a very enthusiastic group and people would raise their hands and jump in. And I'd love to do that, but we're not going to do that. So I'm going to tell you what I think makes sense and what doesn't make sense. So what makes sense are things like preventative care, promotive care, you know, keeping people healthy, disease management. So if somebody has a chronic disease, we actually help them to manage that disease. Providing the right care at the right time, admitting and learning from mistakes, being empathetic, having full transparency in pricing and outcomes, collaboration, integrated care, you know, specialists coming together and talking, educated consumers. What doesn't make sense? Physician self-referral. What do you think? If a physician owns a cardiac hospital and practices in that hospital, do you think they're going to do more procedures or fewer procedures? More? Yeah, I think so. Human nature being what it is. The depersonalized, uncoordinated care that we see so frequently. And I don't know, most of you are very young, but it is remarkable when somebody has a complex episode of care and they go to see multiple specialists, the degree to which the specialists don't talk to one another. So you get different advice, different prescriptions, mistakes get made, communications. It's depersonalized and uncoordinated. So it forces patients to integrate their own care. My mother-in-law, for example, has Alzheimer's, and it took us a good, 2 to 3 years to sort of figure out what that was, go to multiple specialists. And she was living in Iowa at the time, so what does she have? What kind of treatment? And we were just getting remarkable and often contradictory advice, and we were, even though we're not experts, we were the ones that were forced to sort of figure out her care treatment. Why do we force people to do that? The fact that insurance companies second-guess treatment decisions, instead of having a process where we can make decisions based on evidence-based medicine, or recognizing when we don't have evidence that we got to do the best we can, we have a system where insurance companies second-guess frequently to delay treatment or to deny higher-cost treatment and whatever. That's, there's vigorous debate about that. An interesting thing is, for pharmaceutical things. They're double-blind trials. Before we know that a statin helped lower cholesterol. We sort of tested it against a placebo and made sure it worked. That does not happen in clinical procedures. We spent 10 years and tens of billions of dollars on bone marrow transplants to learn that, except in very few circumstances, that does not dramatically improve outcomes. In fact, it doesn't improve outcomes at all. Is that a good use of our money? Mind-numbing regulation. And then incremental payment for unnecessary or inferior care. So you go to your doctor, the doctor screws up, you have to go back to the doctor. Doctor gets paid again for actually makes more money for having screwed up than for getting it right the first time. Yeah.
Just a small anecdote. Yeah. Guy goes to the doctor and the doctor says, "You need an operation." He says, "How much is it going to cost?" The doctor says, "Well, it will cost you $200 a month for 36 months." He says, "Well, that's kind of like paying off a car." The doctor says, "Well, as a matter of fact, I am." But just coming back to what makes sense here.
He's going to be here all week, ladies and gentlemen. Yeah.
Just what makes sense here. Throughout the years, there's been this concept of managed care that
right.
Insurance companies and HMOs have trying to practice. And a few years ago, with the coding systems that became popular, the ICD-10, the CPD-4,
right.
It makes a lot of sense that you can look at a diagnosis, you can look at a way of addressing that diagnosis, as to what was actually done. You can type the drugs that were prescribed, but it never really got any real legs. In a lot of countries, they just took the very basic first level coding, which didn't really give any insight as to what the diagnosis was. So it would say respiratory tract infection, but not respiratory tract infection of the left lower lobe with the Staph aureus is called
right.
is the
right.
organism. This is the drug you should be prescribing. Right. So how can that seem to have fallen by the wayside when it was quite a useful structure for digging down and making sure you've got appropriate diagnosis with way forward and drugs?
Yeah, and so often we treat the symptoms rather than the root cause of disease. A fever is a symptom. A fever is not a disease. I'm going to talk a little bit about the failure of some of the core business models, the hospital business model and the physician business model here in a little bit. But it should. We should have evidence-based medicine. We should have outcomes data. The fact that we don't is, on the one hand, testimony to how complex medicine can be, but on the other hand is a remarkable failure to use technology and management systems to bring about better results. And that, again, kind of gets into where you come out on the regulatory debate. If you move to a single-payer system and have sort of a central operation mandating how treatment's going to happen, will we have the types of systems in place to experiment and find out better ways to do things and then implement them? So it's a really good question, and I'm going to talk about some of the structural issues, and I think some of the answer is built into those structural deficiencies. But the fact that we, not only in the United States, but really in the world, don't learn enough from experience and apply technology in ways to use it. Okay, yeah.
So I'm not completely persuaded that the physician self-referral would lead to these sort of fraudulent, outcomes, at least to the magnitude that I think people sort of necessarily say that they would. But kind of saying, okay, like right now we have the STAR clause and everything.
Right.
One of the arguments that you've articulated that I've heard from many others is that despite that, there's still a belief that much of the care is nonsense. So if physicians aren't able to self-refer today, and we still have all this nonsense, what's driving that?
Well, physicians do self-refer in some sort of...
They aren't able to own, at least one of the laws I heard of with the
Oh, yes.
doesn't allow them to refer, no?
Oh, they can own and refer, yeah.
Okay.
own MRI machines. I mean, there are some restrictions, but yeah.
So that's the hunch then, that because that's in place, that's what's driving all the nonsense care that people are sort of fraudulent.
No, it's not the fraudulent part. It's right now the way Medicare is set up. It pays for anything a doctor prescribes to do. It doesn't matter whether they own the facility or not, but you as a physician will receive more payment for more treatment activity whether it's necessary or not. So we're in an intuitive-based solution shop type activity. The physician has the power of the pen to decide what gets done or doesn't get done. It's just human nature, and people will argue with this and come up with reasons. But if you know that by prescribing more, if you benefit by prescribing more rather than prescribing less, human nature being what it is and very incentive-oriented, will tend to prescribe more rather than prescribe less. We've tended to try to treat that with strong regulatory sort of schemes. I think the really interesting question back here is if we had evidence-based medicine that showed that you got better care for less, then we would have a way to direct away from the resource-intensive way of treating people toward ways that get better outcomes. I mean, one of the just classic cases of this is back surgery. It has increased 15 times in the last 10 years, 15-fold increases, so there's 15 times as much back surgery as 10 years ago. Remarkably more expensive and not shown to have a better outcome than rest, exercise, and stretching. So why does that happen? I'm sure there are huge number, you could have physicians who come in and they'd explain to you what they're doing, but the truth is that's an example of a procedure that is probably done more than it needs to be done. People are convinced they're going to do it. Surgeons who perform it are convinced they should do it, but they also benefit enormously by virtue of doing it. So.
Is there a concern that if a physician has a diagnostic approach or something, it'd be very costly for them to do. It might take a lot of time. And if they discover that somebody has a positive, finding, they would need to make a recommendation for them to get a procedure or something. But we set up a situation where they won't receive any sort of compensation, that there will actually be an under-provision of certain services beyond what would be offered?
Sure. We have both under-treatment and over-treatment. Places like the Mayo Clinic, which have employed physicians, a very strong culture, very evidence-based medicine, philosophically try not to do more than is necessary, and also respect end-of-life care. I don't know if you remember from the first class, we looked at that, and their cost for chronic care in the last 2 years of life was half that of many academic centers around the country. And nobody's going to argue that the Mayo Clinic is inferior in its care to anybody else. So that's a remarkable degree of variation. And you look like a business school student. Whenever you see that much variation, generally speaking, there needs to be process improvement. Part of the way that Toyota, disrupted the entire auto industry is they completely changed the way that you manufacture cars. They did it in teams as opposed to just a pure assembly line. But the way it happened in the U.S., let's say you've got an assembly line and 1,000 things to build a car, and one of the things you got to do is put a seat in, and you got a minute to put the seat in, and people make mistakes, and so the last part of the process was an inspection process that went over the entire car and tried to find out where the mistakes were and then fix them. What Japan did, or what Toyota did, sort of the disruptive breakthrough, was they looked at every process and documented it and said, okay, there are 7 steps to putting in a seat. Here are the 7 steps. I'm going to teach you the 7 steps. So here's step 1. You don't go to step 2 until you master step 1. So they actually built the quality control into the process and basically made the statement, we're going to invest no time or energy on a manufacturing process unless we know it's right. We're not going to spend any time on defective products. So, exquisite detailing of the process to the point where they get it right every time, and it eliminated this inspection at the end. And by the way, their cars, until this year, set the quality standard for the industry and basically put General Motors out of business, General Motors and Chrysler out of business, who are being held together by the U.S. government right now. So that's what I mean when the structural issues and how do we allow disruption to occur so we get better outcomes. I better get moving here. When you think about medicine broadly, there are 4 kinds of medicine. Intuitive medicine, that's when you get a really complex disease. There's no clear course of treatment. You need the best specialists to come together, like at the Mayo Clinic. They have to have a process. They have to talk to one another. And by and large, when you're in that kind of circumstance, you're paying based on the inputs. The equivalent in consulting would be, hiring McKinsey to figure out what your broad strategic plan for the company would be. You're not going to pay McKinsey by the hour for that kind of work because nobody knows how much time and energy it's going to take. You don't know how you're going to get from A to B to C, and it's frequently an iterative process. You try something, you have a hypothesis, it works, it doesn't work, and so on. So a lot of medicine is in this intuitive realm. And if you went back 100 years, almost all medicine was in the intuitive realm. We didn't know that much, a lot of trial and error, a lot of hypothesis. What you're going to see here in a minute is that this is the most expensive, resource-intensive way of providing care, and it's frequently how hospitals still do everything. But as we've gotten more sophisticated, better, we've moved over to evidence-based care, where there's a definitive diagnosis, there's a process. More and more you do it, the better you get at it. You start to be able to look at your outcomes. It's possible to think about a fixed payment for that. It's possible to guarantee the work. I had arthroscopic surgery on my right knee 4 weeks ago, so I'm walking better today than I was 2 weeks ago. But I had it done at Rush at their orthopedic hospital, and that place is just a factory. I showed up. They knew exactly what to do. They told me what time I was going to go home. They told me when I could start to exercise again. Had the follow-up visits. It was just boom, 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 boom. So that's a very different type of medicine than the intuitive medicine. I mean, they've done probably at this point tens of thousands of those procedures. They know exactly what they're getting into. And then the more you get that way, you get down to kind of precision medicine, where there's a definitive diagnosis, there's a clear treatment regimen, little variation in outcome, and the payment tends to be based on outcome. So you go from payment based on outputs or inputs to payment based on outputs to payment based on outcomes. And these are all very different. So let's say you've got an earache. Craziest thing in the world, or your child has an earache. You know it's an earache. You have to get them all the time. You know what antibiotic works. Yet you have to call up your primary care physician. You have to go to the office and have a visit. Physician has to say, oh, yeah, your son has an earache. There ought to be a better way to do that thing. So when there's absolute precision around the diagnosis, you end up with something that can be based entirely on outcomes. And then there's this other sort of category of care, chronic care, disease management. And today in the United States, 3/4 of our health care is in chronic care of some form or another. Now, that's not all bad news. Type 1 diabetes used to kill people. Today, many people live with type 1 diabetes and carry a little pump. Maybe there's even somebody here in the room that does that, self-administered and so on. So it went from an intuitive disease that frequently killed people into a chronic disease that can be managed and dramatically improve the quality of life. So the fact that we have more chronic disease is not necessarily a bad thing. What's unfortunate is the amount of lifestyle activity that now creates chronic disease, like type 2 diabetes, the obesity, the lack of exercise, and so on, so that we're getting an explosion of chronic conditions, particularly as people get into their 50s and 60s, although we're now seeing obesity in young children at young rates. So this is an ongoing condition. The goal is to keep patients healthy. It's treatment that requires regular intervention and or behavior modification. You've got to start exercising and eating differently. And it lends itself to more of a regular payment, like a monthly fee of some kind, so that you're getting the consistent treatment. So let's just, if you believe me, you basically got these 4 kinds of medicine. Right now, the building blocks of the American healthcare system, there are really 2 of them. It's the community hospital and the independent physician. The community hospitals, about 80% of the hospitals in the U.S. are nonprofit or governmental. They tend to be governed by local boards, so very strong community involvement. mission-oriented, so they care for the indigent, they train doctors, they educate the community, they conduct basic research. They're large employers, they raise money. So a place like the U of C or Northwestern will have a very strong local brand. They tend to be vertical in their strategic orientation, so trying to do more things in the service area rather than less, so more services for their people. They employ a cross-subsidy funding model, so if they make money on cardiology and orthopedics, they will use that to pay for things that they don't make money on, like training doctors. If they make more money on certain types of insurance, they will take that money to subsidize the cost of paying for the indigent or Medicaid or, in some cases, Medicare patients. And they receive significant tax benefits, as I talked about. When you get to the primary care physician, which is where most of us enter the healthcare system, you look at all the different things that primary care physicians have to do. They do the straightforward diagnosis and treatment for things like earaches. They oversee patients with chronic disease periodically. They're the sort of front line in identifying an acute disease or injury where intuitive medicine is going to be implied. They provide the ongoing wellness monitoring and disease prevention through the annual physical. They identify problems, and when they spot a problem, and it comes back down in here. The core unit of service is the office business, and the payment, as we just were talking about, is generally based on services rendered. You probably can see where I'm going with this. But so the hospital business model, all things to all patients. Anybody read Clay Christensen's work on innovative, on disruption, disruptive technology, disruptive innovation? Anyway, he had this to say about hospitals. It's a little bit of a long-winded phrase, but as technical and scientific progress enables standardized processes and treatments for precisely diagnosed disorders, hospitals commingled value-added process and solutions shop activities within the same institution, resulting in some of the most managerial and tractable institutions in the annals of capitalism. Pretty strong statement. But what he's basically saying is, as I was talking about earlier, intuitive care really needs a solution shop approach, right? We don't know what the answer is. We need to bring smart people together. They need to come up with a process, trial and error, and you're going to pay for that by the hour. That's one business model. In the evidence-based care, Reggie Herslinger's factory or term, the focus factory, when it's something that gets repeated, where there's evidence-based processes, where you do it over and over, you get better at the outcomes, that lends itself to a different type of business model, a different setting, and so on, focus factory type model. An example of that would be the Shouldice Hospital in Toronto does nothing but hernia operations. That's all it does. 4-day treatment pay. The first day you get diet counseling. Second day they do the surgery. And the days 3 and 4 you recover in this bucolic setting. It costs less to fly to Toronto and have that procedure than to do it on an outpatient basis in most U.S. hospitals. Their success rate is over 99%, and they even have alumni clubs where people who got their hernia fixed together come back and celebrate. So that would be an example of evidence-based care, general, so focus factory. And you're starting to see things like cardiac hospitals, orthopedic hospitals, where the focus can be on that treatment. And then the precision care, you can go to Minute clinics, Walmart, some drugstores, and there'll actually be a list of services on the wall with prices beside them. So if you've got an earache, if you need your ear canal cleaned, it's going to cost you $12. And that's precision medicine. That can have an entirely different business model and location for delivering the services. So the commingling of all of this in one place creates internal incoherence and increases costs. It underprices intuitive care, generally speaking, so hospitals are loath to give up their cardiology business where they do a lot of volume and they make a lot of money because it subsidizes the cost of doing this. But anytime you subsidize, you end up with the inefficiency that comes with cross-subsidy. in a commingled business model, they cannot compete effectively with an organization that does one thing and does it really well. So how hospitals begin to think about the business models and how they treat these different types of care probably has enormous possibility for structural reform and bringing down the cost of care and improving quality. When you think about the primary care physician, they're doing these four things, right? They're doing the precision medicine. They're treating the kid with the earache. They're trying to manage people with chronic disease. They're doing the annual physicals, and then they're sort of the entry point on intuitive medicine. Well, that's the way they've been practicing for 100 years. How many organizations do we do the same thing we did even 5 years ago, much less 100 years ago? So maybe they should hand off these types of things. Let Walmart do it. And on chronic disease management, instead of trying to go see your physician, doesn't it make more sense to have a facilitated network where either a company, you pay a monthly fee to a company, or your insurance company does, they help you manage that. And, oh, by the way, with the internet, you can find people like you out there and share information. You have a facilitated network. So they can get rid of those two things. That allows them to focus on the wellness exam and to kind of go up acuity and challenge specialists. So, so there'll be less specialty care done by specialists, more of it done by the primary care physicians, particularly now since the technology's improved so much that you can do on-site imaging, other types of on-site diagnostics, encyclopedic treatment protocols, telemedicine where you can bring someone in. So the power to extend what the primary care physician does in a cost-effective way that improves outcome is remarkably powerful. So the way it's done today, the commingled business models create inefficiency and higher costs. You need something that focuses on the patient and getting the job done. Now, remember I had that quote at the very beginning about Peter Drucker. It said most businesses don't understand why, the reasons that people are purchasing their products. There's this great case study about a milkshake company, and they were trying to increase their sales, and so they were studying their product, and they thought they were competing with other milkshake companies, and so they tested new flavors. They brought in other types of food to complement it, and sales stayed flat. So they hired a consultant, and the consultant started coming in and interviewing the people that were buying the milkshakes, and it turned out a huge category of the purchasers of milkshakes were buying them before 8 o'clock in the morning. Like 45% of the people of the milkshakes were being sold before 8 o'clock in the morning. And so they started to interview people and said, well, why are you buying the milkshake? Why are you hiring that milkshake for? And it turned out that most people had a 20 to 25-minute commute. They had one free hand that they drove with. They knew they were going to get hungry about 10 o'clock. It took 20 or 25 minutes. So it sort of solved the midday hunger problem, gave them something to do that kept away boredom. And the fact that they were adding all these different flavors really had nothing to do with it. What they were competing against wasn't other milkshakes. It was bagels and jelly donuts and whatever else you would eat in the car on the way in. So once they figured out the job, why were people hiring the milkshake? Well, they did things like they made them a little thicker so they would last longer. They added, pieces of fruit and nuts in them so they would, surprise people and give them a little bit of a jolt while they're driving along. And they made it very easy to come into the store and get it first thing and then pay for it quickly. And once they figured that, sales went up. So understanding what the job is and solving it, I mean, it's good for any business, and it's certainly a need in healthcare. So given all that, what's possible? So, here's a classic 4-panel consultant slide where, here you are today. Are you strategically? Should you be defensive strategically, and operationally? Are you strong or are you weak? And choices are, stay as you are. Stay the course. You can always merge, sell, and acquire. You can re-engineer, but if you don't have financial resources, you're going to have to generate more income in order to make that work. Or you grow, transform, convert, and go to the strongest. So we've just seen healthcare reform unleashed on an industry that's probably going to go through a fairly significant amount of disruption. And individual physician practices, group practices, hospitals are going to go through this exercise. And where they end up will tell us a lot about what the future shape of healthcare is going to look like. So on market-based facility strategies, remember I was talking about the different models associated with the different types of care. So a receiving hospital, and there probably should be fewer of them in the future, but that'll be the place where you do the intuitive medicine. That'll be where the specialists practice, where you take the toughest cases, and we need some number of them. The advanced procedures hospital, kind of a focus factory, that's where if you've got a cardiac condition or an orthopedic need, you'll go there, and that will be done in a very efficient way. The ambulatory networks, more surgeries will be done in these. They'll get closer to the patient, and if it's if it doesn't require an advanced procedure, they'll be done here in the ambulatories. The really interesting question is what happens to your basic community hospital, and what do you do with those? Right now, many community hospitals, because they make more money this way, are trying to go up acuity. So they'll do more advanced heart procedures. They'll do more advanced cancer treatments. But everything that I've seen about quality tells me that places that do more in higher volumes learn from the experience, and they get better both at outcomes and at controlling costs. So the reality is community hospitals should probably be going down acuity and doing just very basic things, and yet the entire sort of culture is pushing executives to make the other decision or go the other way. And right now we don't have a market-based mechanism to enforce that. So what happens to community hospitals is very interesting. And then you need physician strategies that complement what your business model is. If you're using the same approach to physician services in a receiving hospital with a big intuitive care place as you are in an ambulatory care network, you're probably going to lose a lot of money. So coordinate the physician strategies, and then also start to think about how do you get better care at a better price. And that generally means standardization, consolidation, outsourcing. So have business models tailored to the services provided. Have more activity with fewer resources. Really focus on efficiency. Get a tighter relationship between operating revenues and expenses, and correlate capital spending to operating cash flow, real operating cash flow, not artificial reimbursement-based cash flow. So there are all kinds of things you can do to focus on that. Now, one of the really interesting things that will happen with healthcare reform is they're now telling hospitals and doctors that if somebody's readmitted to a hospital within 30 days for a preventable condition, that there'll be a penalty for that. Right now, 20% of Medicare patients are back in the hospital within 30 days. 80% of that 20%, so 16% of all Medicare patients, are in there for preventable items. Either medication wasn't taken, the patient didn't follow rules, there was an infection. Anyway, something happens and they're back in the hospital. So hospitals, by and large, are trying to coordinate care within their four walls. They don't think about what happens after the discharge, and that is a remarkably fragmented area. So, investing in care coordination throughout the entire care cycle is something that health systems are starting to think about. Post-acute care providers are starting to think about it too. And the way the government tends to do things, they phase in reform, so it's better to learn early. And so, you just look at all these things and say, okay, what's the right business model? Should it be separate? What should my comp structure be? And the idea that you can take a hospital-based operating model, which doesn't even work very well within a hospital, and apply it to a post-acute model is just ludicrous, but that's in fact what's happened in many cases. So getting some linkage between quality and cost, focusing on healthier populations, having more transparency and accountability. And I've mentioned the Veterans Administration before, but that's a population-based management approach to health care, arguably a very sick population. 80% of homeless are veterans in the United States, believe it or not. So they went to a population-based care model. They have an electronic medical record that follows veterans around the country, around the world. So whenever they go to a veterans hospital, you can pull up their medical records. About 3 years ago, they did a massive study of their capital needs. They have very old hospitals. Average age is 50 years. That's the average age of a hospital, non-veterans hospital in the country is about 10 years, so very old buildings. But they decided it would be a better use, rather than building new hospitals, to invest in technology and home health care, and that's what they've done. And they are getting significantly better outcomes. They've closed thousands of inpatient beds, and they're doing it at 3/4 the per capita cost of Medicare with a very sick population. So it shows the power, potentially, of integrated care. So what we're saying to health systems now on care coordination is go now and go fast. Figure this out. But here's a kind of a big question. There's a consultant I like that used to do hospital turnarounds, and he used to say, eat the big toad first. And everybody knew what it meant. I don't know where it came from, but basically it was address the biggest problem first. So one of the things I've been wondering about lately is we know that community hospitals are vertically integrated. We know that they bond tightly with their communities. We know that they want to provide more services, and yet their focus has almost been entirely on health care, not on health. So at what point it's a big question, do health systems accept responsibility for improving community health? Most health specialists would argue with conviction that the biggest problems confronting the United States aren't whether you're treated well in a hospital or not. It's our lifestyle issues and the degree to which they create chronic disease. So it's our society's most compelling need. There's no, community health lacks institutional support. A little bit of a typo there. It's consistent with a vertical strategic organization. It supports the mission orientation of tax-exempt hospitals. It could provide an alternative revenue source, particularly things like continuing care retirement centers, which are basically real estate and wellness. So it's where people go live in independent living units, and usually in their 80s, and then as they age, they can go to assisted living and ultimately to nursing home status. Sort of the goal being what they call compressed mortality, live long and die fast. So an alternative revenue source, and it has lower societal cost, and that should be societal, and also better societal outcomes. So the questions are, do you expand focus to wellness prevention and promotion, facilitate networks for disease management, start to have things in mall-like settings for things like diabetes care, rehab, have partnerships, have tailored services, embrace senior living, CCRCs, and have a consumer focus so that people can get through the system more efficiently with better outcomes. I think this is a really interesting question. The University of Chicago is trying to coordinate care with other hospitals on the South Side. It gets a fair amount of flack for it because there isn't a high level of trust. But that's still within the hospital context. We'll treat your very acute diseases at the University of Chicago. We'll take the more routine things in the community hospitals. But what if we started thinking about the whole South Side as a population whose health care could improve, and we focused on things like nutrition and exercise and treating diabetes and hypertension and some of the other things that plague urban inner city communities. So that's eating the big toad. So I'm just going to end with a couple of slides here. I had the slide up there of what makes sense, what doesn't make sense about healthcare. And when I advise systems and their strategic planners, I said, when push comes to shove, aren't you supposed to default in areas that make sense, that make you proud to be a part of the healthcare system? So all the things that make sense go that way. So I kind of like, this is from Rush. This is their mission statement. It spells out I care, but I really like the values that they elaborate here. Innovation, respect, collaboration, excellence, and accountability. And they are committed to compassionate care. If we could really bring all of those to bear in healthcare, integrated care, concerned about the patient, outcomes-based, remarkable, we can see some interesting things. The Ascension Health System, or not the Ascension, the Adventist Health System has something called Creation Health, which is a wellness initiative that they give to every patient who comes into their hospitals, encourages them to exercise, to drink lots of water, get plenty of rest. Geisinger, an integrated system in Pennsylvania, now gives a guarantee for certain procedures. If you have a heart operation with them and you're back in the hospital within 30 days, you don't pay any more for it. They take responsibility for that payment. So you get the relentless pursuit of quality and better outcomes. You get empirically based decision making, appropriate patient-centered care, business models tailored to the diagnosis, embrace transparency and prepare for change, and always focus on value, price, and outcome. So what could the U.S. healthcare system be like? We all want something ultimately that's competitive, responsive, consumer-driven with clear metrics for value and each dollar spent. There are two basic jobs to do in healthcare. It's figure out what's wrong and then fix it. We tend to commingle those in these one institution and in these physician practices, and we make it a lot more complicated and a lot more expensive, and we create a lot more errors. So disrupt this current conflated hospital and physician delivery models that put all this stuff together and make the pathways much more complex. So new delivery models will be tailored to precision diagnosis. They'll apply different metrics for output, value, and payment. They'll adapt to technology. They'll recognize when customer needs shift from outcomes to quality and convenience. There comes a point in a consumer experience where the quality is good enough that all you start to care about is convenience. How many of you, well, maybe you do, but I've got a cell phone that does all kinds of things, but as long as I can send emails on it and talk to people, that's about all I care about. It's got all this other stuff it can do. I'm not going to pay any more for the other stuff, but it's there. And that's because the quality has gotten to a point where I'm not going to pay any more for that. In the early days, I needed a cell phone that didn't cut off and actually sent messages. So there I was willing to pay a little more for that. But there comes a point in every product cycle where we have that shift. So let's figure out how to do that in healthcare. And so when something shifts from intuitive medicine to evidence-based care, we make that shift. We have a business model that applies to that. And when it gets into the realm of precision medicine, we push it there, and we treat disease management. So I actually think the biggest thing holding us back in healthcare reform in terms of cost and quality is we don't have business models tailored to the appropriate diagnoses. And you can think of business after business after business that has gone through this cycle and been disrupted and either adapted or gone out of business. Mainframe computers gave in to mini computers, gave in to personal computers. Now we're giving into iPad and cell phone. I mean, it's just this cycle that we go through, industry after industry after industry. We're still in kind of stage 0 to stage 1 in healthcare. When it's complex, it needs to be centralized. You go to where the specialists are. It costs a lot of money. But we're getting good enough now at evidence-based medicine and some of the precision medicine that we can go to alternative settings and get the experience in a lower cost. So at the end of the day, we want a system that does these two basic jobs, figures out what the diagnosis is, does the appropriate therapy in the right setting with evidence-based, with outcomes, something that we can put value around. And at the end of the day, both keeps us healthy and treats us when we're sick or injured. So that, anyway, brings us to the end of this three-part mini-series. And I've got 3 minutes for questions, but I'm happy to stay and take questions for a while. But anyway, thank you for listening to all this. The goal at the beginning was to give you a better understanding of the system, where it works, where it doesn't work, and how it could potentially reform itself. And hopefully you feel a little smarter about that than you did before. And my only advice to to you as people mostly on the verge of going out into the business world is figure out what you do well and do it. And then secondly, the customer is always right. So thanks very much. Any questions? Sure.
Just see, I think for preventative care, especially, one of the big things I think is that the routine care, someone wants to kind of grab the word and say physician is sick or something like that.
Yeah.
Maybe changing that question to be really safe and save some hospital, changing our order, that is improving community healthcare outcomes, providing lower costs.
Yeah.
So maybe we should be getting tax exemptions for that, and it might be not giving things to say people who don't have insurance or something like that.
Well, it certainly makes sense to get a checkup once a year to see what's going on. And the fact that people don't do that or don't do that for economic reasons is just crazy. Because early detection and prevention obviously save money in the long run and improve quality of life. One of the ironic things is that companies frequently care more about their employees' health than employees do. Companies lose valuable, they spend all kinds of money training employees and getting them to understand their culture and be efficient. And the more days lost to illness and injury, the greater the cost burden. So one of the things I expect will happen, one of these disrupting factors, is that companies will start to take more responsibility for the health care of their employees. There's a printing company in Milwaukee that a dozen years ago was just really frustrated with its how its medical care costs were going up. Its employees weren't any healthier. And they started small, but they hired their own primary care physicians. They started doing regular checkups with their people, 30-minute checkups, not short ones. They built in disease management programs. They subsidized nutrition and exercise. They forced, or didn't, but they held people accountable for it. And their health care costs went down, and their employees were healthier. And now that's, as they've gotten better and better at it, they are now outsourcing that to other companies in Milwaukee. So will employers say enough of this already, this conflated business model, and start to do some of the basic things themselves and get better and better at it and disrupt the system? Because clearly the system doesn't work as it should, and it's very expensive and it's very complex. Yeah.
I have a question on the focus on the outcome-based model. In theory, it certainly makes sense. Every other profitable business essentially operates based on results. It's obvious. It's nothing worth arguing about. But then you look at it from a doctor's perspective, and in an already incredibly litigious society where they are, there is a big fear of getting sued. From what I understand, it is having an impact on people even deciding to go down that path and join that career. Isn't that putting them more in the role of God and saying if someone dies or something goes wrong, you're going to be even more likely to get sued? It kind of doesn't, if it's outcome-based and something goes wrong and they don't get paid for anything, like how do you discern between outcome-based that they really could have done something different and true malpractice and outcome that is
I guess I believe that doing a better job protects people from that. But when you get to evidence-based medicine, the way it's done now in a hospital is you're in there with all of the really intuitive cases, and there are multiple. Yeah, so once they the disruptive force is the proper diagnosis. So once we figure out and conclusively that you've got something that can be treated in an evidence-based fashion in a focus factory, then we ought to treat you in an evidence-based fashion in a focus factory. And just like Toyota putting seats in cars, if we do it in the right way and we do it over again and we learn from our mistakes, we'll get better at it, and we'll be better at it just like the hernia hospital is in Toronto than just about every other hospital in the world. But we have to have ways to move healthcare out of an intuitive, very expensive setting into evidence-based settings, precision settings when they're ready to do that. All right. Well, good. Well, thanks, everybody. Have a good evening.